Everyone, and thank you for joining us for today's webinar, Bridging Mind and Heart, the Role of Psychology and Ambulatory ECG Monitoring in Cardiovascular Health. We still have some folks that are logging onto the system, so we want to give them time to join. So please bear with me for another minute or two as we wait for them to log on, and then we'll begin today's webinar. Thanks. For those of you still logging on, I appreciate your patience. We are getting ready to start the webinar. We want to give folks just another 30, 45 seconds or so to log on to the system because we still see folks coming in, and then we'll begin. Thank you. I see a couple more people still trickling in here. We'll give it just a few more seconds, and then we'll be able to begin today's webinar. Thanks so much for your patience. Okay. It looks like we could probably get started now. I appreciate your patience for those who've been hanging on for a minute or two while others have joined. I'm Joe Sasson. I am the Chief Commercial Officer and EVP of the Ventures arm here at MedAxiom, and I am thrilled for the webinar that we are going to present to you today. Before we do that, I want to make sure that I inform you on how you can interact with us during the webinar. The first way is that on the lower left-hand side, you will see a chat button, and that chat is where we are going to place today's slides. So you'll be able to access them. You will also see a number of times that chat button activates throughout the presentation because we will continue to post those slides throughout the presentation today. It will always be the same slide deck. It's just we want it to be available to folks who join later, and they would not be able to see anything in the chat from before they're joining. So do understand that's exactly where you'll get the slides, and you can download them directly from there today. On the other side of the screen, on the right side, is a Q&A button. And if you have any questions for the presenters, then the Q&A button is where you can type those in. Now, we will probably wait until the end of the presentation today and then take those questions so that we don't interrupt the presenters as we go. But I wanted to make sure that you knew the difference between the two buttons and how to best interact with our team. So feel free to send them at any time, and we will get to those as appropriate. So as we get into today's webinar, I think what's really exciting for me as we talk through this today is that we're really going to focus on two components. One has to do with the clinical side of ambulatory ECG monitoring, and the other has to do with the mental side and the psychosocial side. And so what we think about always is the care delivery side, and where we may not spend enough time historically is on the psychosocial. And so when you think about if I have a consumer grade wearable that says I have an arrhythmia, or with my PCP, primary care physician, and they say, hey, you might have some kind of arrhythmia, then I have to say, what's next? And there's a lot of fear and anxiety that comes with that. And then I get to the doctor's office and, the cardiologist's office, and what are they going to do for me? And what is that care pathway? And what is that going to tell them? And what is that going to be like for me as a patient? And if I get discharged from the hospital and I have to go home and I need a device after a procedure, or I need a monitor after a procedure, what does that look like? Then what, for me? And we have to look at these things from the perspective of both the clinician and the patient. And so the clinician is saying, well, what are my next steps along the care pathway, given the guidelines and the symptoms that are present? And many of you on the phone or on the call today are administrators in programs and CV service line leaders. And you're asking the question of, how do we structure our program properly? And how do we create optimal care pathways, both what happens in our facility and outside of our facility? But the patient piece, when we talk about patient experience, we normally think about it as what is the patient experience while I'm delivering care? The question is also, what is the patient experiencing when I'm not delivering care? What kind of stress and anxiety are they going through? And how worried are they about their potential outcomes? Because this is not knee pain, right? And no offense to orthopedic surgeons, but if I have a cardiac condition, I'm actually not saying I'm going to go to bed with a hurt knee and wake up with a hurt knee. I'm saying I'm going to bed and am I going to wake up at all? Or can I go on this walk with my spouse or my grandchild? Or can I go play tennis with my friends? And that level of anxiety and worry does not create the right mental state for treatment and for recovery at all. And so today's webinar is going to focus on the care pathway, the enabling technologies, and really the patient's life experience, not just the direct care experience. So that for me is just a really exciting webinar to bring to all of you today. And to do that way better than I could, we do have Dr. Jazairi, who's a cardiac electrophysiologist at the Trinity Health System in Michigan Heart, which is in Ann Arbor. And then we also have Dr. Sears, who is a professor of psychology and a licensed psychologist as well at East Carolina University, and works in their Heart Institute there in the Department of Psychology and Cardiovascular Sciences. So I am excited to bring both of these folks to you today. I'd like to start by having Dr. Sears introduce himself and his work and his background, because it's not one you've heard about a lot inside of cardiology. And then we'll move on to Dr. Jazairi, and then we'll jump right into today's webinar. So Dr. Sears, I'd like to welcome you to the webinar today. Thank you so much for being here, and would love to have you do your introduction.
Well, great, Joe. Thanks so much for your introduction and for this opportunity. The very idea of psychology being integrated into cardiology is exactly what drove me to the kind of work that I've done. I've been in clinical practice now for 30 years. And what's interesting about my practice is that it's completely embedded within cardiology. So my role at East Carolina and at the East Carolina Heart Institute is as a professor of psychology and cardiology, with the idea being that psychologic practice is integrated in cardiology, where I have responsibilities for clinical care 2 days a week on a clinic. I have responsibilities for research, and that I have a large research grant portfolio and studies across the psychology of cardiac electrophysiology and also in cardiac surgery. And then finally, in terms of training and fellowships, I'm the co-director of the Cardiology Fellowship and train PhD psychology students, doctoral students there at the Heart Institute. So I have the three legs of the stool, if you will, of academia, and each really enhance each other. And it's a pleasure to be here to talk some about what I think is a pretty challenging clinical situation.
Thank you so much, Dr. Sears. I appreciate that overview. Dr. Jazairi, I'd love if you could give us the same, and then from there, feel free to launch right into your slides.
Thanks so much, Joe. Really appreciate the introduction and the opportunity to be here. My name is Ali Jazairi. I'm a cardiac electrophysiologist at Trinity Health, Michigan Heart, based in Ann Arbor, Michigan. I'm part of a group of 5 electrophysiologists here, but a broader group of about 30 cardiologists based here in Ann Arbor, Michigan, and we have satellite locations in the surrounding areas. In addition to clinical care, we're involved in training physicians here, as well as a variety of other allied health professionals. We have a mission which also involves clinical research and clinical trials. And I'm excited to join you here today to talk about ambulatory ECG monitoring and how that ties in with the psychology of cardiology. So moving into an overview of the ambulatory ECG portfolio, some disclosures, none of which pertain to today's talk. So starting off, I think when it comes to looking at ambulatory ECG monitoring from a 20,000-foot view, to perform this successfully and implement it in your practice, there's a whole ecosystem involving people, processes, and various platforms. So there's a lot of moving parts to implementing a successful ambulatory ECG monitoring program. And some of the factors that we don't necessarily consider on a day-to-day basis involve payer issues, as well as different types of wear options, algorithms that are involved in each individual monitor, patient factors, and physician factors. If you could advance the slide, please. So although Philips has an end-to-end portfolio of offerings in the ECG space, today's conversation is specifically going to focus on two types of therapies: mobile cardiac telemetry, or MCOT monitoring, or ambulatory ECG monitoring with an extended wear Holter, or e-patch. And those are displayed down below. So I think one way to frame sort of the different applications and use cases of these different monitors is to look at the different environments in which we practice and where we interface with patients. Today, I'm joining actually from our clinic where I've been seeing patients this morning, and that is highlighted here as one of the potential interaction points with patients. But you can see below in this diagram that there are a variety of different diagnoses that typically are evaluated with one of the aforementioned monitoring platforms. And some of the common diagnoses are listed there. So syncope, atrial fibrillation, patients presenting with palpitations, new neurologic symptoms, suspected stroke or TIA. So whether it's an ambulatory setting or whether it's ER discharge where patients are being first approached about the idea of ambulatory ECG monitoring, that's one touch point. Secondly, there's the post-discharge pathway, which you can see in the middle column there. So this involves patients who have suffered, for example, cryptogenic stroke, or in my world, post-ablation patients in whom we're often wanting to monitor for recurrence of arrhythmia or new arrhythmias, or patients who have recently had structural heart procedures, where depending on what we are looking for specifically, that may help guide us as to the appropriate type of monitoring that we want to select. Lastly, and I think it is certainly not least, is our interface as subspecialists with the primary care providers. And certainly within our system, and others who are joining us for this webinar may also be able to relate, there is somewhat of a variability in terms of people's comfort, particularly those who are outside the cardiovascular space, when it comes to what is appropriate monitoring, how do you choose the appropriate monitor. And so there are a lot of thoughts there that could be explored further. Lastly, there are these two different monitoring platforms that I mentioned previously with extended wear Holter and the MCOT. I think there are a variety of things that help guide us as to which we would choose for a particular patient. But one of the things that I think shouldn't be lost on our viewers today is that the duration of monitoring, and we know this from other literature and other types of monitoring, certainly makes a difference. And so in a recent compilation of data from Philips, they demonstrated, as shown here, that about 25% of the actionable findings in a patient with a 30-day MCOT prescription occurred after day 14. And this is pertinent because for some of our monitors that we use, the maximum duration may be 14 days or even less. And so duration of monitoring should also be considered when deciding on the appropriate monitoring modality. So I've talked a bit about the monitoring options when it comes to ambulatory ECG monitoring, but I think just as important as what type of monitor you choose as a clinician to diagnose or work up a particular complaint or diagnosis is just as important, if not more important, to think about the patient's experience and how they interface with the prospect of having ambulatory ECG monitoring. And so with that, I want to turn it over to Dr. Sears to talk about the patient experience.
Well, thanks very much. When thinking about the patient experience, it's often the case that we think about what are the challenges that our patients face, but we can acknowledge that both patients who are trying to identify or live with cardiac disease have significant challenges. Our patients experiencing the unknown have to immediately start with the idea of managing and addressing the fear of the unknown. When we look for cardiac conditions and use technologies, we're often asking patients to face fears that are quite unusual for them, and it really is the fear of the unknown. So what do patients want? What do they want from a wearable? I would suggest that the patient experience spins on this goal: to make the unknowns known. And there's a second part to that goal. The second part to that goal is the idea of creating safety, a perception of safety in the context of the unknown or in the context of perceived threat. We know a little bit about the psychological experience of heart disease. Over the last 30 to 40 years, there's quite a body of literature that's been created about how human beings deal with this condition and all of the innovations that have come along in the last 30 to 40 years, how patients have experienced this disease, experienced the use of technology, both from a physician perspective and from a patient perspective, and then somehow try to make sense of it and then evaluate their quality of life. That this process of disease by technology, by patient experience, and by outcome is something that is beginning to be well understood. It starts out with the idea that most cardiac conditions do have a patient's psychological component, that patients perceive and experience certain kinds of emotions like fear, and it translates into their behavior from all the way from cardiac risk behaviors all the way through to rehabilitative behaviors, that the psychological component manifests itself both in emotion and in behavior. But what we're learning now in this diagnostic space that we didn't quite understand before is the power of ambiguity. There is a body of literature about how all human beings sort of steer away from situations where there's large amounts of ambiguity. And in the case of cardiac conditions, we can hypothesize that what we can imagine is wrong is often much worse than what's actually wrong. Further, we can often recognize that patients who have ambiguous concerns will often magnify the affective component. The unknown, frankly, might be more scary than the known that has some danger to it. And that's, I think, an interesting idea we can talk some more about. Further, we know that what happens after the diagnostic process still has some important technical and patient insights. That is, when we've completed monitoring, the kinds of feedback patients get, the kind of comprehension they get about both what was found or not found, and what their relative risks and the relative dangers are from that remain important benefits or derivations from the monitoring process. And I think it's often lost, and I'll make some comments about that as we go forward. What we know about the psychology of heart disease, as I mentioned, is that we now have very large meta-analyses and large studies that basically point out around or approximately a third of our patients across cardiac disease severity have depression and anxiety. So mood disorders and anxiety are a 1 in 3 experience. Stress, of course, this elevated idea that you're up against some challenges, much smaller study reported in this meta-analysis. We have other data that sort of is consistent with the idea that whether we're talking about the definition of depression, anxiety, and stress, they're very much all in play here. But my number that I keep in mind as an index of suspicion is roughly 1 in 3. And I think it might surprise some of our viewers that medical severity is actually not a good predictor of distress. I think the sort of the doubter or heckler in the audience might say, what do you want, Sears? You want everybody to be happy they got heart disease? I mean, that's a silly notion. And I'd say, no, that's not the notion. But I think the notion is that patients with heart disease need to be refining and compiling their resources psychologically to be able to move through the disease process, to minimize the dysfunction and minimize the distress. So sometimes people say to me, well, it's just the sicker patients. They're always the worst off. And the data is actually paradoxical. Some of the healthiest patients, actually in a nice study from Denmark, showed that those with the most benign conditions were often the most distressed. And rather those patients that we often see in clinic that have more severe conditions, let's say ventricular tachycardia, ventricular fibrillation by history, cardiac arrest by history, they often, while they are also distressed, it's not somehow the case that there's a gradient that matches medical severity. That's not held up in the data that exists right now. More recently, my lab has focused on these diagnostic uncertain patients, so looking at patients with implantable loop recorders, and then leveraging the technology in loop recorders that also has an accelerometer. that measures patient movement. And what we've shown is that patients with loop recorders have very low levels of physical activity as detected by their implantable loop recorder. And what this suggests is, at least relative to other patients in EP clinics, while that's not an easy comparison to do statistically or clinically, the raw values associated with loop recorder patients suggest a very low level of activity, much lower than our patients with identified atrial fibrillation or identified ventricular tachycardias, suggesting that, wow, this medical ambiguity may actually be quite hard on patients, which we already suggested it might be true affectively. This suggests that it might be true behaviorally. Further, we know that when patients are uncertain about what's wrong with them, it often leads them into more fear behaviors. They do things like disengage from their lives. They do things like cancel trips that are perfectly safe to go on. And they begin to withdraw in ways that, if don't immediately create distress, are certainly associated with diminished quality of life. You know, this was just an interesting headline that came out in the last week or two, where this idea of medical ambiguity, uncertainty about what's wrong, it's not just devices. It also has to do with how fast we can get them into our clinics. And this article was actually an industry white page, if you will, about the time to see a cardiologist. And in this case, the data suggested that it was approximately over a month before somebody could say, hey, I've been referred to a cardiologist. When will I get my first appointment? Suggesting that by the time our patients even get to that diagnostic encounter to initiate monitoring, they've already had a month. Their impatience, their distress, their fears have already been sort of well worked or well practiced. A month worth of worry can really shake you up. And so this very idea about how do we get people seen a little bit quicker, certainly we see this in the atrial fibrillation space, where you have people with paroxysmal atrial fibrillation presenting to the ER and trying to figure out ways in which we can get them seen by EP to prevent more ER visits and ultimately some unnecessary medical usage. One of my colleagues, Lindsay Rossman, recently published a paper looking at wearables, the condition of consumer wearables, if you will. Funny for me to use the word condition, but consumer wearables, in which she matched 176 AFib patients that had some that were users of their own sort of consumer grade watches and monitors versus non-users. And what she showed was that the users were way more likely to have high rates of symptom monitoring and almost a preoccupation with symptoms. So those who sought out such watches actually do a lot of watching. And then those with more concerns were more likely to seek watches and monitoring. And interestingly, 64% said, well, I feel safer. I feel better that I'm getting watched. So that's good, right? We got almost 2/3 saying, hey, this helps me. But Dr. Rossman and her colleagues did show that 20% said that the watch and the wearable, whatever means it was used, created intense fear and anxiety. That the byproduct of monitoring was actually more symptom intensity, more preoccupation, and therefore more anxiety. So when we think about the sort of knowledge base we have right now of wearables, I think technology does give us info to deal with danger, to help us say, hey, I know that palpitation you had, we saw it this time, and we can recognize that's a benign change versus a dangerous change in heart rhythm. But technology can't give us everything. Some mysteries will go unsolved. And so what we're doing is really targeting suspects for trouble, right? We're trying to figure out who's got a dangerous suspect in that readout versus certain annoying suspects, if you will. And I think part of the point I want to get at as we think about how we deal with medical ambiguity in the cardiology space is to talk about this is only one marker of well-being. That part of well-being is a multifaceted set of components that involve the kinds of thoughts and feelings you have every day, the thoughts of actions and behaviors you take each day, and that rather than being obsessed with becoming the Sherlock Holmes of your own heart, it's more important for you to be the quality of life master who's trying to plan things and live life and take a lot of selfies. And so the very idea here is let's move beyond simply worrying about medical mysteries all the time, which we will do with technology, but also to match that with the idea of building a plan that no matter what the outcomes are, we will have a plan, we will create a safe space for that patient with whatever is found on these on the various monitoring technologies. So with that, I'd like to open it up to my colleague and begin our discussions.
Dr. Jazairi, Dr. Sears, thank you both so much for being able to provide just such great context around both the clinical side and then the psychosocial sides. I'm always fascinated, Dr. Sears, by this piece that is critical to patient well-being that has largely gone overlooked, and maybe not in your circles where this is what you've done for 30 years, but as you can probably attest, I think in the last 5 to 6, we've started to see much more of a shift, at least I have, nationally around, hey, this is something we need to pay attention to. And I can identify some practices that have been working on this for 10, 15 years, but I have to say the number which I could identify has grown greatly in the last 5 or 6. So I'm excited about it. I'm glad that we're spreading this knowledge, and thanks so much for sharing it. Dr. Jazairi, I think one of the pieces that I see a lot of is sometimes confusion around what monitors do I use and when. I see this a lot. It's okay, well, let's monitor. And the 4 that we hear about the most are, of course, going to be Holter, extended Holter, event, and mobile cardiac telemetry, or MCT, or MCOT, however you want to refer to that. And so we hear it used so many different ways. What I'm curious about is what types of monitoring are you using the most in your practice today? And my part B on that is, and how are you making the decision around which monitors you're using?
Absolutely. Great question, Joe. I think it's a double-edged sword, right? We have many options now, but it's also made our decision making a little bit more complex in terms of what's the right monitor for the right patient. And so I think one is, what are we specifically looking for? What symptoms does the patient offer? And then secondly, the duration of monitoring. And so whereas in that patient post aortic valve replacement, I want to know right away if there's any, or with minimal delay, if there's any sort of abnormal finding that might change my management for that patient as it pertains to the possibility of pacemaker implantation. I could contrast that scenario with another patient who has symptoms that may or may not be cardiac in nature, sort of the patients that were somewhat alluded to in Dr. Sears' discussion, where they have a symptom, they have fear of the unknown, they have, they're looking for clarity, in which case, the monitor might be tailored to a shorter duration. It may not need to be necessarily mobile telemetry. And so in that case, I'll oftentimes go with an e-patch monitor in somebody where their baseline risk, I think, is pretty low. They don't have any cardiovascular history based on the information they offer. And the duration of monitoring, say, for example, they have daily symptoms. I think that a 14-day or 15-day monitor, I could certainly hope to capture something. So these are some of the considerations. Hopefully that gives you a sense of the different things that clinicians might be thinking about when they choose monitors.
Got it. That's really helpful. If I could dig just one more question in there, specifically around like MCT, then mobile cardiac telemetry as a service. When is that a trigger for you? When would you decide that that's the right approach?
I think in a patient where I'm concerned for potentially actionable arrhythmia, where as soon as I find something, or if I think that I may find something, I'd like to know that information sooner rather than later, and not wait for the turnaround time of the patient receiving the monitor, completing the monitor, sending it back, getting a report made. There's a lot of steps involved in that, and sometimes it may be more prudent to have actionable information in a more timely fashion. I think that's where MCT really shines. But also, I think if being pragmatic, if there is a doubt about what you may be confronted with, or depending on the characteristics of the patient in front of you, you may choose to have that more timely information transmission. As all other things being equal, you may have a preference for that.
That's really helpful. Thanks, because I think that's one where there's always a lot of debate about its usage. Is it overused? Is it underused? And when should be used? So your answer provides a lot of clarity. Dr. Sears, I'd like to ask you, what about either the choice of the wearable monitor, if that affects maybe patient well-being, or just the fact if there's a form function of monitor that really helps with patients with their lifestyle and activity and those types of things, what are you seeing as the most amenable for patients when it comes to needing a wearable for diagnostics?
Well, I think the key with any of the technologies is to get a shared experience there, right? To have the patient understand why and what we're doing. It was mentioned, for example, the symptomatic versus the asymptomatic patient, right? So the asymptomatic patient's like, why are you bothering with this? And the symptomatic patient is, can't you bother some more? You know, can't you come home with me and monitor me as well as the monitor, right? Because there's fear there. So I do think how the patient starts the process matters. And so getting some buy-in both from the patient and potentially a family member about which of the monitors we're gonna go with and what their relative benefit or yield should be based on that. So it's more so that not all patients start in a little bit different spot, and their expectation about both what's going to be found and its valence, its negative, its seriousness, or its dangerousness. And when we talk about those things, it helps to simply understand that when we orient to the patient and say this is a symptomatic young person, this is going to be somebody who's going to bring some distress to the table, as opposed to the elderly gentleman that's been through a lot in life and says, I don't feel anything, and even if I did, I've just tapped my chest like some sort of tough guy. They're going to have different experiences. So I think part of it is exactly what Dr. Jazaziri said, which is, thinking about, well, who is this patient? What are the likely yields? What are their likely orientations to the clinical encounter and their expectation for what will happen?
That is helpful, and that shared mindset between the physician and the patient, or the care team and the patient, I think is probably the most critical. So I agree with your assumptions there and your statements. My question then comes from the patient experience side of having to wear like a 30-day monitor. When you think about that, I've got questions around showering, and it's summertime now, so swimming, do I have to change out the batteries? Am I capable of charging those? When you start getting into the patient experience of being monitored for a longer duration, as we talk about MCOT specifically, how does that affect their mental state to have to wear something that long? Is it reassuring? Is it even create more anxiety? I mean, what have you seen there?
Well, I think two parts. First is that if you get a shared goal here. Hey, we're going to work together to find out if there's anything here we need to make sure we address. Let's get that goal shared. And then secondly, let's recast this as not this old thing I got to wear for 30 days, but hey, this is my partnership. This is my team. Me and my doctor and my hospital or medical team, we're a team. They need me to do this and I need them to do that. So rather than say, oh, it's summertime and I don't want to wear this, you say, nah, this is how we do it. This is how we create a team experience to create the kind of win that we want, which is I want to be safe and sound when this is done. I want answers. I want to make the unknown known, and I want to know that I'm safe to go about my life after this. So it goes back to those goals we talked about. Can we make the unknown known, and can we feel safe? So, hey, we need a 30-day discomfort. We need a 30-day you wearing our team badge so that at the end of this deal, you feel safer and we're in the game together.
Yeah. Putting the patient in the team approach is just, it's got to be done. And that sounds to me like just such a core way of engaging them mentally as well as physically in their care.
Yeah, and let me add to that. I mean, I think there's a tendency to throw everything at shared decision making. So, oh, if we just do shared decision making, everything's great, great, great. That's not what I'm saying here. I'm saying that create the team in which we share the goal of getting you in a situation where we know what we got and we know that you're safe. That's what we're going for. Now, even if you go, what if we find something bad? Okay, but then we create safety in that. Okay, so I think if you got to be sort of um, focused on the idea that the teammateship, that shared goal drives the behavior longer term to get that 30-day buy-in. And these are hard to do. We're in a hurry. We're in a hurry, but being smart, right? This is about being a clever clinician and thinking about both who we got in front of us and what are we trying to achieve together.
Yeah. Yeah, you're not asking for the patient to be the coach on the team. You're asking for the patient to play their position.
Exactly. Because we share in one to win. We know
Yeah.
that.
Yep. So play your position well so the team can win.
Yeah.
I want to come back a little bit, if I can, Dr. Jazier, to selection. So there's a document that was released last year, the 2024 ACC expert consensus decision pathway, that really had to do with arrhythmia monitoring after stroke. But regardless, there's a number of clinical decision documents out there from ACC and HRS and AHA. And what I'm curious about is how important some of those guidelines are to you in your decision making around which monitor that we use. We talked a little bit about that, and then this question kind of came to me. But how does that affect your decision making and how you navigate the care delivery for the patient?
That's a great question, Joe. I think the consensus documents certainly help to standardize care, and I think nowadays, especially more so than before, there's a focus on making sure that we are meeting certain target metrics, quality metrics, and so on. Even recently, there was a more recent document even released on how to become an atrial fibrillation center of excellence. What does that entail? When you think about how long we've been treating a condition like atrial fibrillation, that only now we're getting to a point where people are starting to develop standards for that. So I think sometimes the consensus documents and guidelines lag a little bit behind what people are actually doing in practice. But I think just as from a 20,000-foot view, it's helpful to have that there as from a standardization perspective. When you look at a large practice like ours, we have physicians taking care of patients, we have physician assistants, we have nurse practitioners, everybody having a different type of training and a different background. And so getting everybody on the same page as to what is this problem that we're confronted with and what's the appropriate way to tackle it, I think it's helpful in that regard. But that being said, I mean, I think when it comes to post-stroke monitoring in particular, that you had alluded to, I mean, the duration of monitoring, I think, matters. And so, having the ability to have mobile telemetry out to 30 days, I think, is important. And I think having that actionable information coming in a timely fashion also is helpful because it helps us make decisions surrounding anticoagulation. Furthermore, I would say, we're fortunate in the EP space in that we can offer not only wearable patches, but also we do implanted monitors. And I think Dr. Sears also discussed about his experience with ILRs. And so there's some debate about what is the most appropriate modality for monitoring a post-stroke patient. But we interface with other specialties when it comes to specifically the post-stroke patient, namely neurology. And so what we found in some of our practice sites, particularly at some of our smaller hospitals, they may be the ones who are mostly managing patients' care after a stroke. And also that would cover, arrhythmia monitoring in indicated patients after a stroke. And so whereas they may not always be able to get an implanted device if they feel like that's the most appropriate, when you bring it to the monitoring space and the patch monitoring space, that somehow, I think, liberalizes things to the point that you have a variety of different clinicians, both all invested in the care of these patients. And now they have options that they can say, okay, we're going to monitor you for the next 30 days until you can get perhaps a follow-up with an EP physician to talk about either the results of this monitor or what the next steps might be if the monitor is negative.
Got it. Yeah, I keep hearing this message around the importance of the 30-day in terms of making sure that you have enough diagnostic yield. I'm wondering, and this is kind of where I was getting to go with the issue of guidelines, and as the guidelines say, well, for this patient, this is the type of monitor that we might need, how are you balancing some of that with your own judgment? So when do you kind of override those guidelines, if you do at all, to say these are guidelines, but this is where I'm starting to see exceptions in what patients need? Is there specific things that stick out to you, or is that not really that individual decision making? Is that fairly aligned as it is with the guidelines?
I think for the most part, it aligns pretty well. But I think getting back to one of Dr. Sears' points, I think it is really about the conversation you have with the patient and setting expectations early on. Like as was highlighted, some patients, I've definitely been sitting across from a patient where I mentioned the word monitor and they roll their eyes and I said, well, what's that about? And the response is, well, I've worn those before and I just have a terrible reaction to it, or it's just a drag, I don't want to do it. And you're almost having to convince someone about the value of the monitor in that case. So I think, that certainly can be one among many factors to consider in deciding the duration of the monitoring. So, depending on the type of symptoms they're reporting and how likely you think it is that you're going to capture something within a certain duration of time, our bias in EP is we always like more data, to be honest with you. So if I have the opportunity to monitor somebody for longer, and particularly if I'm trying to provide that patient with reassurance, I would prefer to have more data. So even if we say, for example, that the vast majority of diagnosis X can be captured within this duration of monitoring, but that's not everybody, and so and you're dealing with the patient that's in front of you. So I think guidelines are helpful to provide a framework, but I think at the end of the day, your accountability is to the patient that's sitting across from you. So if it makes sense, if for that particular patient, their state of mind, the problem you're trying to diagnose or manage, then maybe you would choose to do a longer duration monitoring. And I don't think there's a problem with that. And I think that actually is highlighted by people's utilization of wearables too, where you see people, they just want to have all their data all the time. I think that it's beyond medicine. It's a societal issue.
Yeah, I like your answer there because there's a little bit of psychology of you there and the psychology of the cardiologist saying more data is better. And that's generally true, right? If you want to map, it'd be nice if we had a map of the entire ocean because we would be able to say there aren't any crevices we don't understand down there and we have complete control. And I think the same thing's true with cardiac diagnostics. The more that we can see, we believe that we can make sense of. But it's the unknowns that make it challenging for us. And so more data does often give us a sense of control. And as you know, and I love your summary there, which is, yeah, who are these people who are these crazy consumers that are putting up these EKGs all day long? And the answer is people that want some control. And even the advertisements from the companies say, wow, you could really know more if you would just test your heart more often with this monitor in the consumer space. So this is definitely the future where we think about cardiac technology and cardiac rhythm information giving us both an informational high as well as some degree of anxiety relief for some.
And more anxiety for others as they track it over and over and over.
Yeah, and my point is that, of course, there's going to be anything that's powerful enough to help is powerful enough to have a side effect, and so we're gonna have something that produces a lot of good and a lot of insight. But for some people, it's going to be an anxiety promoting experience, and what we need to do is not go, oh, I wish that weren't true. We say, hey, that's all right. Let's make psychological aspects cool. Let's make it part of all the things we do. I mean, that's what marketers do. That's what if you want to help human beings move through the world, anticipate their experience, anticipate their response, and already build in a plan for it. And I think that's exactly what electrophysiologists have done. They've slowly we're getting a back-end response to the data. We're getting a better here's what we're going to do when we get the data, not just, wow, we got data, which, 10 years ago was, wow, we got data. Now it's, wow, we got data. Now let's talk about what it means. Let's discuss your overall plan about managing your relative risks. And let's look at that rather than be terrified because we found something. Rather, we say, we're looking for things. If we find this, we'll go in this direction. If we find that, we'll go in that direction. But either way, we're going to be on a direction that you feel safer in, that we know a plan for, and we're ready for.
That's great. I want to make sure that we leave some time for questions. We're getting a little bit tight on time. I don't want to take away that last thought you were about to say, Dr. Jazayeri. So after you share that, I'd love it if you could just say, where do you think the technologies are heading and how can we get better at diagnostics? I'd love to hear that after you share whatever I interrupted.
Absolutely. No, no problem at all. No, I was just gonna wholeheartedly agree with that last sentiment Dr. Sears expressed, which I think is, you know, at least in the practice that I have here, I think that monitoring is not a end in and of itself, right? It's a highway, it's a road, a pathway, if you will, to get somewhere. And so I think it needs to be framed in that way. And I think that really helps to facilitate these conversations with patients to say that, we're going to do this monitor. We think this is the duration of time. What are we looking for? What are the possibilities? What if the monitor shows nothing? In exploring these possibilities with people, I think it really helps to achieve buy-in, regardless of whether you're talking about 7 days, 48 hours, or something like a 30-day monitor. It really helps to, I think, get a patient buy-in and then make the whole experience successful for everybody involved. And as far as the other part of your question about what does the future hold, I mean, I think we already have many options to choose from, as highlighted in today's discussion. But one of the things that we didn't talk as much about is, I'm a subspecialist as an electrophysiologist. As Dr. Sears, we're working in very specialized clinics. We have a different type of patient population, a selected patient population. But what about the frontiers? What about the primary care population? In our practice, we have a large primary care group that refers to the subspecialties, and many of them, there's a lot of variability I see in how comfortable people are with ordering monitoring. And I think partly it may be due to that conversation and what are we going to expect to see and how do we manage the results of this. And if folks are not comfortable with that, they may feel like they shouldn't even order the monitor at all. Whereas then some of those patients end up in my clinic and they have no data to go off of, and we have to start that process kind of de novo. So I think there is an opportunity there of sort of expanding the frontier of where patients are interfacing with these monitors so that they can have more informed conversations when they do meet their specialists to talk about, okay, what do we do with this? Do we need to do longer duration monitoring? Are the data useful? And how do we manage them? And then I think the other space that I would point out is the wearable space that's already been alluded to in this conversation today, is that as we continue to grow in that domain, and patients are developing more and more ready access to these technologies, we need to know what to do with those data. We need to find ways to manage these data, because for me to sit there and go through everybody's ECGs on their phone that they've been collecting over the last 3 months, it becomes sort of an exponential task. You can imagine if everybody is carrying around one device or another. What do we do with all those data? And so to the extent possible, if we can sort of try to validate wearable data and make it into a clinically actionable form, companies like Philips and others maybe would, that's an area where maybe they can partner with us as a way of taking these third-party data and making them more clinically useful, since we do have such reliable medical grade monitors through these partnerships. I think that's a direction where we could hopefully take the wearable conversation to the next level and actually start to use those data in a more meaningful way.
Thank you.
I think patients will be a part of that plan eventually. I agree 100% with the amount of data overload is here now. And, every conversation must include the word AI, so I'll just conclude it here. But beyond that, I do think there's a day where patients are going to be more involved in their care, more like diabetes care, more where our patients have a little bit more degrees of freedom than presently, where we're not very comfortable with very much degrees of freedom. But I think they're going to snatch it. I think you're going to snatch some of that autonomy back. And, we'll want to support it. We'll want to have a great teammate there, as I've mentioned, to have the patient and family part of that team. And the answers are out there. We're not ready for all of these yet, but we're going to move in these directions.
Dr. Shears, let me ask you for parting thoughts before we open it up for questions. And what I'd like to focus around is, how can programs do better? We've got hundreds of programs inside the MedAxiom network. How is it that they can improve their view of the whole patient and focus more on some of those psychosocial factors? What are some easy 1 or 2 steps they could take to move in that direction?
Well, the first thing is to have some partners, right? To conceptualize comprehensive health as a goal for your clinic or your facility. That is, we're going to not just save lives, we're going to improve quality of life. And I don't mean that in a glib, soundbitey way. I mean, we're going to look at the contributions of other aspects to outcomes. So, for example, at our facility, I like to say that I want to create the most confident and active heart patients anywhere, meaning that I want our patients to come through this building and feel confident about the diagnosis and their care, confident that they know what's wrong, confident that they know what to do. And then on the active side, so confident and active. On the active side, I want to use wearables to recognize that their behavior outside of the clinic and around their lifestyle is active. Because the movement process, the movement of our patients, how they engage in physical activity is part and parcel to their outcome. The things that are exciting in life usually involve moving our emotions and moving our bodies. That's just how it is. And that's where quality of life is. And so I think that idea of the overarching goal is that we want a comprehensive solution. And I think we want that for our family members when they go get care. We should want it for our patients. And ultimately, I see a vision in which cardiology sees itself as a big, broad team that has a lot of different talent types around. And I think when we get there, we're going to improve these kinds of broad outcomes. We already said we want broad quality of life outcomes, but then we do something highly technical and expect a cascade of quality of life to flow from it. But in fact, if you want a cascade of outcomes, you got to have a cascade of interventions. So I think that's how we get there.
I love it. Thanks to you both. We still do have some time left. So what I'd like to do is move into some questions from the audience. This has been a great discussion. Thanks to you both for your presentations. But now let's transfer into some audience questions. Well, thanks to you both. That was just very exciting, and really appreciated all of the insights that you were able to share with us. What I want to do now is, as I said, prompt folks to submit questions through the Q&A button. So at the bottom of the screen, if you click the Q&A button and submit a question there, we will see that come through on our side and be able to answer those. So that's kind of what we'll be doing right now. I see one coming through now here. So I think we could get a variety of perspectives on this one. How do you see clinical grade, kind of regulated, medical grade cleared devices like ePatch or MCOT coexisting with a direct-to-consumer wearable? So how are you balancing between the patches like MCOT patches and the Apple Watches? How do you balance that? What does that look like? I'd like to start with you, Dr. Jazayeri, on that one.
Sure. Thanks again, Joe. I think it depends on the patient. Kind of one of the themes of this webinar, I think, who's sitting across from you. Some patients already come with a wearable device. I've had plenty of folks who bought it as a gift for their partner, ended up diagnosing themselves with something, and that's where the journey begins. And I've had other patients who, whether it was through an ER presentation or seeing their primary care physician, were referred for ePatch or MCOT, and then I'm seeing them to review the results of that. Once they're established with me, it generally depends on what their preference is. So we typically, a common scenario would be post-ablation. I'm seeing the patient, we've done an ablation for atrial fibrillation, a common condition that we treat. And then we're talking now about rhythm monitoring, long-term rhythm monitoring. And so I usually go through the options with them and the pros and cons of each. Obviously with ePatch, duration up to 14 days, MCOT longer duration monitoring, what the telemetry offers. And then I think one thing that patients typically like a lot about wearables is the ability to have that control, something that Dr. Sears talked about in his comments. And so depending on their personality and sort of perspective, we'll kind of settle on something that works well for them. And a lot of patients, they use both. I've had folks who sent me wearable data that was really difficult to interpret, and the signals weren't good despite education. Our nurses have done a great job of educating folks on how to get good tracings. Despite that, we can't really tell if it's AFib or just sinus rhythm with PACs. And so then I'll ask them to do something, medical grade monitor. So those are some of the considerations, but I think jury's still out as to what's the best strategy. Another thing I would add is that although we have great wearable technology, nowadays, cost continues to be a concern. So as the devices become more sophisticated, not everybody can necessarily afford some of the top of the line devices out there. And that's a conversation I've had recently with a number of patients. And so we had to take that into account as well.
Got it. Thank you for that. And I think the two do coexist, and there's a consumer use case that many times will trigger the medical use case. As I look at those devices, Dr. Sears, and I could have an Apple Watch on my wrist every day, but I'm putting a monitor on when my doctor thinks there could be an issue, or to make sure everything's okay, post procedure. So when we're looking at it, that the two, how does that affect kind of the patients from my everyday monitor to now there's an issue, or we're looking for an issue?
Well, what's the old saying? Curiosity hurts the cat. Well, this is curiosity today buys an Apple Watch. And so that's certainly one part of the user case is curiosity. It's like, well, I could monitor my rhythms. Well, why? I don't know, just because I can. Versus there's a reason, there's a symptomatic or a concern. And in both cases, there's a degree of control being sought. I think the issue here is really that we're just entering a new age where the availability of medical grade technology is available at consumer levels that are not medically indicated. And there's going to be some sort of connection to clinical use cases. I suggested in my talk, for example, that it might be a month before somebody with a symptomatic complaint could be seen by a cardiologist. That month is the perfect time. People are going to be running around, using their cell phone based one or watch. So I think there is a bridge here potentially in the future. It's got to get worked out a little bit more. But I think to say, well, I'm not going to pay attention to consumer grade wearables, that's just not good enough. Then I think you're going to miss the boat. It's here already. Of course, we need better information systems, but there's a bridge here between the consumer level and the medical grade. And we're seeing it already in EP clinics. We just need a little bit more support probably in how we do that. And there are some technological solutions coming, I think.
I think that's right. I mean, you can stick your head in the sand, but it's not going away. That's for sure. So it's just getting, I'd like to say better. I'd also like to say worse. Better from the technology available, and worse from there's so much data floating around now, and what are we going to do with that and process it? Again, I will ask folks if you'd like to put something into the Q&A, please do. We probably only have time for another question, but we'll make sure to get all of your questions answered afterwards if we don't get to it here. Another question that has come across is actually kind of in the middle of what we just talked about, between consumer grade wearables and what a cardiologist may put on for diagnosis or for follow-up. And that is, the question here is PCPs, and I'm seeing this across the country too. Do you see PCPs being able to triage patients using extended wear Holters or MCOTs to reduce unnecessary ED visits? And again, I think I'll start with you, Dr. Jazairi, and then when you finish there, maybe parting thoughts. Same with you, Dr. Sears, and then we'll close off the webinar. So the PCPs in this process.
Yeah,
Dr.
I
Jazairi?
touched on a little bit in the body of the webinar, as far as, I think that is definitely one of the frontiers. Certainly in our practice, that's evident. We have a great primary care collaboration in Ann Arbor, but despite that, there's different levels of comfort with these different monitoring modalities. And I think there's a role for education about what to use when. And I think certainly if you're talking about these two different modalities with e-patch and MCOT versus wearable devices, I think certainly there's an advantage to medical grade monitoring, in terms of a first step. If you were going to kind of break it down into what's low hanging fruit versus maybe more aspirational, just to educate people such that they feel comfortable enough ordering these monitors in appropriate patients. And then, we obviously, in our practice anyways, we're the ones who interpret those studies. And so often patients will be seeing us afterwards. And so either myself or one of my colleagues will have interpreted that monitor. So it's sort of, we are taking on that responsibility as cardiologists and electrophysiologists, and being entrusted with those data. I think the wearable debate, just simply because of the volume, I had read somewhere that maybe wearables by 2030 is going to be a $400 billion industry. I mean, it's not slowing down anytime soon. So we're going to, just as we're facing it in the subspecialty space, primary care, I'm sure, is dealing with it. And so I think there's probably even more uncertainty in that clinician population about what do we do with these tracings? Are we comfortable interpreting them and giving patients diagnoses based on them? And so I do think, or at least I see sometimes in our practice, that the solution in that situation is to send the patient to the ER. Say, okay, if you're having these symptoms and they're concerning, I'm not going to pass, give an opinion based on these wearable data, or they're not good wearable data. They're controversial, difficult to interpret. So go to the ER, and your symptoms are concerning. And so I think that frontier is still not clear how we're going to kind of cross over. So
Okay.
in terms of Dr. Sears kind of touched on this, but I think we just need better systems for managing the volume of data. Whether that incorporates AI or some other proprietary software, to take these third-party inputs and make them actionable and interpretable for us on the clinician side. I think that's ultimately what it's going to take. And then finding a more streamlined way of integrating those wearable data into the EMR so that we can have those things at the point of care. Even, you see nowadays, if you are using a certain app, it will say, do you want to incorporate the data from your sensor, your watch, or your weight scale at home, or something else that monitors your sleep? So already on the consumer side, these tools are being developed, but how to get that to the medical grade and level that we need, so it's actionable in the clinic. I think that's kind of where we need to go with wearables.
Okay.
My comments about primary care are that that's the frontier, because I think cardiology is going to continue to need to move toward primary care, more collaboration. We're already needing to collaborate now with the data being pushed back and forth. I think ultimately there's an opportunity for cardiology and particularly cardiac electrophysiology to reach toward primary care, to start to use similar kinds of communications, similar kinds of devices, so that there's some unity in the patient experience. I think there's nothing worse than feeling like you're falling as a patient, falling between two sets of people that you count on. And so improving that flow between primary care to cardiology with data, with wearable information, just going to improve everything. And so I think there's a tendency sometimes for cardiology to be focused on its own farm, but there's a big community of farms out there that have to do with primary care that are also going to be part of an overall process. So I think the future is exciting. This is good stuff ultimately, but we've got to continue to evolve our overall management.
Well, I appreciate that, and just hearing that perspective for what the patient experiences and being caught in between two providers. That's a really great way of kind of representing the challenges from the patient's perspective. So I want to thank you both. Again, I knew this was going to be a very different webinar. I said it at the beginning than what we're used to. The two perspectives combine so well, not only to educate our membership, but for what practices need, what physicians need to hear, what patients need to have considered for their behavior and their healing. So thank you both so much for the time, for sharing your expertise, and for being here with us today. I know we're a little bit over time, so thank you all for staying with us. And this will be the conclusion of today's webinar. So thank you, everybody. Have a wonderful rest of your afternoon.